All right, let's talk about Burkitt's lymphoma. Now, this isn't just one of the fastest growing tumors in humans, it's a disease where the treatment itself can be one of the biggest dangers. We're going to break down all the high yield clinical pearls you absolutely need to know, whether it's for your exams or for your practice. And before we dive in, a really important shout out. All the fantastic clinical information we're covering today was provided by Dr. Mohammed Al-Nagi Mohammed. We're so grateful for his contribution to this explainer.
So, here's our game plan. First, we'll nail down what this disease actually is. Then, we'll look at its different forms and what causes them. After that, we'll cover the classic diagnosis, unpack the really interesting paradox of its treatment, and finally, talk about how to prevent a major clinical crisis.
Okay, first things first. What exactly are we dealing with when we say Burkitt's lymphoma?
The two words you really need to burn into your brain here are high-grade and rapid proliferation. Seriously, this is not some slow, smoldering cancer. Its doubling time can be less than 24 hours. That incredible speed is the one feature that drives everything else we're about to talk about, from how it shows up in patients to the dangers of treating it.
So, we know it's incredibly fast, but who gets it and what's going on under the hood, molecularly, to drive that kind of aggressive behavior? Let's take a look.
Burkitt's really has two classic faces. On one hand, you've got the endemic or African form. This is the one you see in textbooks with that massive jaw tumor. But then there's the sporadic form. This is what you're more likely to encounter in places like the US or Europe, and it's often tied to immunodeficiency, especially HIV. And this one doesn't show up in the jaw. It usually presents as a huge mass in the abdomen. That difference in presentation is a really crucial distinction. So what's the engine driving this thing? Well, on a molecular level, the absolute hallmark is the c-my gene translocation, usually T814. What happens here is the c-my gene, which is basically the gas pedal for cell growth, gets moved right next to a gene that's always turned on. The result? That gas pedal is just slammed to the floor 24/7. And on the viral side, we've got the Epstein-Barr virus, EBV, which is a major player, especially in the endemic form, where it's found in almost all cases. Okay, so you've got the clinical picture, you know the molecular drivers, but how do you lock in that diagnosis for sure? Well, it all comes down to what you see under the microscope. There's a classic, totally pathognomonic finding, and this finding just perfectly illustrates the biology of the disease. That sky you see, it's a dense, dark ocean of lymphoma cells that are dividing like crazy. But because they're growing so fast, they're also dying off just as fast. So what are the stars? Those are the cleanup crew, macrophages that are swooping in and gobbling up all the dead tumor cells. This beautiful, unforgettable starry sky is literally a snapshot of the tumor's insane turnover rate.
Now let's switch gears and talk about treatment. Because this tumor is so aggressive, we run into this fascinating clinical paradox, where its cure is also its most immediate danger. It's a real double-edged sword. So the cornerstone of management is, of course, intensive chemotherapy. And it makes sense, right? Because the cancer cells are dividing so quickly, they are incredibly sensitive to these chemo agents. This usually means you get a very fast, very dramatic response. But here's the paradox. This is the catch. When you kill that many cancer cells that quickly, they all burst open at once. And when they do, they dump all of their contents, all the stuff that was inside the cells, out into the bloodstream. This massive release triggers a really dangerous metabolic emergency called tumor lysis syndrome. And this is what that metabolic chaos looks like. The cells dump a ton of potassium, which can cause life-threatening heart arrhythmias. They release a flood of phosphate. That phosphate then binds up all the calcium in the blood, causing hypocalcemia. And as all the DNA and RNA breaks down, you get a huge spike in uric acid. All of this together is just a toxic storm for the kidneys. And the most feared outcome is acute renal failure. So this is absolutely crucial. You can't just give the chemo and cross your fingers. You have to see this coming. You have to anticipate and actively prevent tumor lysis syndrome before it even gets a chance to start. So how do we get ahead of the crisis? Well, prophylaxis is everything. It starts with aggressive IV fluids to keep the kidneys flush, but the real star of the show is a drug called rasburicase. And the key thing here is that it's given before the first dose of chemo to get the body ready for the metabolic hit that's coming.
The way this works is actually pretty brilliant in its simplicity. We know that tumor lysis is going to unleash a flood of uric acid, which is not very soluble and loves to form crystals in the kidneys. Rasburicase is basically an enzyme that grabs that uric acid and chemically converts it into something else, a compound called allantoin.
So why is that little conversion so important? Well, get this. Allantoin is 5 to 10 times more soluble in water than uric acid is. That simple change turns this dangerous crystal-forming gunk into something the kidneys can just easily flush right out. It's an incredibly elegant way to protect the kidneys and prevent them from failing.
So we'll leave you with this to think about. We've seen how the insane proliferation of Burkitt's is what sets the stage for tumor lysis syndrome. So based on that principle, what other aggressive, high-grade cancers would put you on high alert for this exact same complication? Thinking about this helps apply this crucial concept way beyond just this one disease.